I just want to be sure.
That way, you come 30 minutes early, watch the recording, and then we'll start the
Are
we ready?
Yeah.
She said no zooming.
It's recording.
Okay.
Okay.
Within a hospital, most crash carts are stocked the same, which is a good thing. So no matter what floor you're on or what department, the crash carts are arranged the same. Now, from hospital to hospital, they may be a little bit different, okay? But within the same hospital, they'll be the same. Whenever you use a crash cart, it's important that you call pharmacy and you call central supply right after the code, or even if you have to break into it just to get meds if you don't have a full code, but you have to use it for emergency situations, you need to be sure you call pharmacy and you call central supply to get it restocked. That way you're not without a crash cart, especially on the floor. We're going to quickly kind of go through the drawers, and I'll kind of tell you how ours is arranged. In the first drawer, we have IV supplies, we have different size syringes, we have things where we can do blood draws, all different types of things we need for starting IVs and so forth. There's goggles, worried about splashing, extra bottles of saline, assortment of needles and so forth that we can draw up. The second drawer is usually the airway drawer, and in there you have different size ET tubes, and so during a code situation, the physician will tell you, okay, I want a size 7 or a size 9 ET tubes. You just find the appropriate size, hand it to the practitioner for the intubation process. We also have the laryngoscope in here that we'll use, so that needs to go to the practitioner. Oral airways are kept in this drawer, and so we have all different types of oral airways in case you need those. Here's a mouth-to-mouth mask. Of course, during a code, we usually use a BVM, and there is a BVM in our room you'll use today. There's extra suction tubing, all different types of oxygen tubing and so forth that you might need during a code situation. Also, like on the floor, as far as oxygen, there's usually an oxygen tank that's kept beside the crash cart. Now, in our simulation room, we'll use the oxygen on the wall. Okay? And as far as our simulation room, all of our oxygen works. So I'll show you when we get in there how to turn on the knob to get it to go. You'll actually set the flow meters and everything. And even our suction works. So if we use suction or anything today, it's all functional in there. The next drawer is more IV supplies. So normal saline is the solution of choice during the code. Okay, so we always usually use normal saline. If something else is hanging during the code, we'll switch it out and put up normal saline, because that's where we want to push our drugs through. We have all different types of IV tubing in this drawer, different drip sets and so forth you might need. The next drawer is our medication drawer. And this is where all the medications are stocked, the next two drawers for a code. Medication drugs come prepackaged for us already. And in the hospital, we use ACLS protocol. And so the drugs that we use during the ACLS protocol, whatever algorithm the patient is, or whatever rhythm the patient's in, we follow an algorithm. And so all of the drugs are dosed based upon what those algorithms tell us. And so they come in a box, and I'm going to let you kind of play with these so you can get used to assembling them. Here's lidocaine. Whenever the practitioner tells what drug you're going to administer, you just pull it out of the drawer. You have to open the box. So it takes kind of a minute to assemble. Pull out your syringe and your drug. You'll take off your lid here. You'll take off your lid here on your drug. And you'll assemble them. This. You hand it to the nurse passing the drug, and then it's ready to administer. Okay. So then you'll take off your needleless system, because we do everything needless. Okay. And so I'm going to let you kind of play with these. That way you can kind of get used to assembling them and working with them, because it does take a minute to get used to working with these drugs. But like I said, they're all prepackaged, and here's lidocaine, 100 milligrams. There's calcium, epinephrine, atropine, whatever we're going to use in a code. Some drugs, of course, are a lot larger in size, and this is sodium bicarb, so quite a bit bigger. For the purpose of our simulation, you will actually be pushing drugs today. We have it set up where you can push. We reuse our syringes, so some of the syringes just have air in them. So we want you to actually go through the simulation and push in air. If there is medicine in them, you can go ahead and push it, okay? Because we have it fixed today where we can administer fluid. I'm gonna let you kind of go ahead and pass me back there, kind of practice putting those together, because you'll be responsible for that. During our simulation today, I'll play the role of the physician, and so I will tell you what drugs it is that we're going to be administering. Okay, so you won't have to, you know, based upon the rhythm, you won't have to know the algorithm today. So I'll let you know what we're going to be doing. Now, we do not have code drugs for all of the drugs we'll be administering for our algorithms, and so I just have a syringe drawn up with air in them. So so some of the drugs won't be in an actual box. They'll just be in a syringe. And so there's vasopressin, amiodarone. So, because you know, I want to follow the algorithm the way it's supposed to be followed. So some of our drugs will have that. Okay.
Did I just do that?
Huh?
Can you push it into mine?
Yeah, you probably did. It leaked a little. It's okay. It's no big deal. Just screw it in, and once it's screwed in, it's ready, and then it's ready to push.
Okay.
But yeah, kind of play those because it takes a minute to get used to them, and in the code we're moving pretty quickly, so you have to be able to, you know, get the caps and everything off those.
I think that would be so much fun.
And then our next drawer, what we have is just different supplies you need, like a central line needs to be put in. And so we have kits for that. A lot of times we'll have cut down trays, whatever is needed. And we usually don't like keep pulmonary artery catheters or anything like that in a crash cart. We keep those stocked in our cabinets if we need those, like in the ER or ICU. But there are things that we can use for, you know, to put in just basic central lines, internal jugulars, things like that. So that's in that drawer. And then the bottom drawer, it depends upon what hospital you're in, what you're going to see. Usually the bottom drawer, we just have kind of supplies here, but usually the bottom drawer will hold a lot of respiratory supplies. Okay, so some extra respiratory equipment or whatever that you may need. When you are working with a crash cart, like I said, it depends on what hospital you're in and what kind of crash cart they have. This one actually has an unlock and a lock latch here, but a lot of our crash carts actually have a plastic holder that goes down here at the bottom, and you actually have to break that. So you just lift up the lid and break that before you're even able to open any drawers. Okay, so once again, that'll kind of just depend on what hospital you work at. There is always on top of the cart a documentation sheet, and so this is what you'll document with the events during the code. And so whatever time the code starts, you'll put that there, whatever rhythm the patient's in, whether it's asystole, VTAC, PEA, whatever it is, you'll write that here. If you ever shock the patient, there's a thing for joules, how much we shock them with, any meds we give in the route and in a code, unless we don't have an IV line in place. In a code, we give everything IV, but if we don't have an IV line in place, there are some code drugs that we can actually give down the ET tube. So sometimes if you don't have an IV going and we need to get those drugs started, then we can squirt them down the ET tube. Okay. So in that case, you could put ET tube. The response, was there a response? Was there not a response? The response would be like if your patient's rhythm changed. So say we were at asystole and then we went to VTAC, then that would be the response. If there's no response, you would just put a 0 there for no response. You know, if there's a pulse, blood pressure, you know, when we're doing CPR, you'll just kind of check that, saying we continued CPR, we're using the BBM, how much fluid we've given the patient, or what's infusing, and any other comments. The comments would be something like the ET tube was put in, the size of the ET tube, or maybe if we put a central line in, or IV started, so anything else that happens. At the bottom, it's important that you fill this out as well, and you put whoever was in the room during the code, who's giving meds, who's the physician, you know, who's the respiratory therapist, all that needs to be filled out. Because this is actually the record of events during that code situation. This is the documentation we use. Also on top of the code card is your defibrillator monitor. And this is our defibrillator monitor. There's kind of all different types and sizes, but they all work the same way. But defibrillator monitors actually have various functions. And as far as turning it on, you just push the on button. When we're using a defibrillator monitor during the code, we very seldom, unless your hospital doesn't have them, we very seldom use the actual paddles anymore. And these are the paddles. You've also seen those before. And they actually put on the back of the defibrillator monitor. We really don't use these anymore. Instead, we use the adhesive pads, and they work the same way, and they deliver the shock just like the paddles, except you're not having to lean over the patient to deliver the shock, and it's actually done through the pads. And so what you do is you just pull the backing off and then place these on the patient. Now, for our simulation experience today, we're not going to pull the back off of these and put them on cement, and we'd never get them off. Kind of the texture he is, we wouldn't be able to remove the pads. So we have some double-sided tape. And you're actually going to put these on, but it'll just be with tape today. And it shows you on the front of the pads where the placement goes. And here's the normal placement. Now, you can actually put paddles on as well from front to back. So once again, it kind of depends on where you work, kind of practitioner's preference or so forth. I know we always had a physician in the ER who wanted us to put them on, you know, front to back like this. But most of the time, they're going to go in this position. Okay, so we'll actually put these on today on the patient. This will actually hooks up to the defibrillator monitor. There's cords that'll hook up, and when we want to shock a patient, it depends on the algorithm. Usually, we always shock at 360, and so we'll do 3 consecutive shocks to begin with, like with ventricular rhythms, and that's the only rhythm we ever shock is ventricular rhythms. But so the practitioner say, okay, let's shock the patient at say 360 joules. You'll hit your energy select button here, and this is the knob that changes your joules. So you'll go up to 360, okay? And then you just hit charge, and it'll go through the charging process. Now during the charging process, whoever's running the crash cart, you need to, once it gets charged, let me kind of stop that for a second so you can hear me. Whoever's doing the charging, don't have people clear until the charging is complete, because that's a few seconds we can continue CPR. So once the charging is complete, then whoever is running the defibrillator, you're the one that's going to be doing the crash cart, assembling the drugs, and hand them to the nurse passing the meds as well. You need to make sure you turn around, look at the bed, and say, all clear, everyone clear. You're all clear, because you need to be sure you actually turn around and you visualize the bed, because if you are standing up against the bed, you know you're going to get a shock. Okay, so whoever's doing this, please turn around and make sure that everyone's away from the bed for safety reasons. Okay, so you just say clear, all clear, everyone clear. While you're turning around, making sure everyone's clear, everyone steps back from the bed. We deliver the shock, and then continue on from there. I will tell you that once again, the rhythms that we do shock are ventricular rhythms, VFib, VTAC, that are pulseless rhythms. Patients don't have a pulse. We usually start shocking at 360, and we do 3 consecutive shocks. Shock, 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 with no space in between. We just shock them consecutively, and then we check for a pulse, you know, check for a rhythm, and then continue CPR. And then from there, we do drug shock, drug shock, drug shock, until we can get the patient converted or back. Okay, so that's kind of how the ventricular rhythms work. So once again, you'll hit your energy select. It's at 360. You'll just hit charge. It'll go through the charge process. Now, when we're using the pads and these are on the patients, you deliver the charge from your defibrillator monitor here, and you'll just put shock, and it'll deliver. Now, for the purpose of today, this is not going to be connected, so you'll actually have to use the paddles today to deliver the shock, to get it disengaged. And so to do that, you just push both buttons, like that. Okay. If you are using paddles instead of the pads for some reason, and in some places you will, these work exactly the same way, and it'll tell you where these go. So this goes at the apex of the heart, and this one goes right beside the sternum, okay? And once again, you do the same thing. You can actually charge, though, from the paddles. You have a little charge button, so you have to do your energy select. And so you can push energy select here, or you can do, this actually turns, and you can do an energy select from the actual paddle. This one, ours is kind of hard to turn. It's actually easier to do your energy select here. And then you just hit charge, and it'll go through the charging. And you're standing over the patient. Be sure you're not touching the bed. And then you push both buttons together, and that delivers your shock. Okay. So for the purpose of the code today, whoever is running the crash cart, we will have the pads on because I want you to get used to placing the pads on. Because this is what we really use in clinical setting.
Sure.
And once you're doing any shocking, you'll just actually shock from over here at the crash cart. So you'll do your energy select, set it, charge, and you'll discharge your shock from pushing the two buttons, okay? Be careful with these. I mean, this is a real defibrillator monitor, and we don't want anyone to get hurt. And we were working with this in one of the critical care mini sessions, and there was a shock. These were laying here, and because there's kind of a magnet or so forth, there was a shock that was delivered to the cart. And there's like burn marks over here, and there's like burn marks on our house. So be careful with these today, you know, because like I said, it is a real monitor. So just kind of, you know, hold them here and you know. Okay.
So
just a
you
warning,
said
be
we do
careful.
3 consecutive.
Do it for a bit. Yeah, that's the algorithm for like the pulseless VTAC or VFib. So you just do shock, shock, shock. Okay, and then you check for a pulse, you check for rhythm, and then you'll continue CPR.
Do you have to reset it and recharge?
You have to recharge between each one.
Okay.
You sure do. Now, I mean, this one is, the charge takes a little longer in the hospital. It doesn't, I mean, some of the ones that we have in the hospital, it does not take that long to do a recharge. For some reason, ours is just, our battery's a little slower, so it takes a little bit longer to do a full recharge. So, no, we're not quite done. Some other things that we use the defibrillator monitor for, some things that we can do, is we can actually pace the patient. And these are patients who like incomplete heart blocks or things like that, or their heart rate's really slow and we need to pace them until maybe we can get them to the cath lab or something like that. And we actually deliver the pace through your pads. Okay? So this once again is connected to a cable. The physician, you can just hit pacer, and then the physician will let you know the rate and the current that we use, and we set that, and then it actually delivers pacing rhythms to the patient. We usually sedate the patient a little bit when we're doing any pacing because they can actually feel that. So we want to make them as comfortable as possible. But that's one thing that the defibrillator monitor does. And also we can do synchronized cardioversion, which we use that a lot. Our defibrillator monitors a lot for in ER and ICU. And if our patients are in some really rapid rhythms, like rapid AFib, that's symptomatic, if they are in SVT, supraventricular tachycardia, then we'll cardiovert the patient. A lot of times we'll try drugs first, like something like adenosine or cardizem, to try to convert the patient. And if that doesn't work, then we'll do a synchronized cardioversion. Works basically the same way. We put the pads on the patient, and then we just go into synchronized. They'll set the current. Usually when we're doing synchronized, we set a lower current. We don't do 360. We start lower and then move up. And then you of course, you know, charge, and then you hit shock, but it'll synchronize the shock and deliver the shock where appropriate according to the rhythm to try to convert the patient. Once again, we're delivering a shock to the patient, so it's very uncomfortable, and so we sedate those patients heavily before we do any cardioversion. Okay. I will tell you that these pads, they do have a jelly on them, so they don't burn the skin. If you are using the paddles, you need to be sure that you always, and there's always jelly kept on the cart as well, you need to always be sure you put jelly on the paddles and rub it in, because if not, you're going to burn the patient. Okay, and it actually just makes the exact mark of the paddles. So always make sure you don't put, you know, the direct current on there. Make sure we have some jelly to protect the patient. Okay. Any questions about the defibrillator? Okay. We're not going to do any pacing today. We're not going to do any synchronized cardioversion. I just want you to know that there are other functions that a defibrillator monitor does perform. Also, I will tell you that we hook the patient up to the leads, okay, and then the rhythm is displayed right here on the monitor as well, okay. Now, for the purpose of today, we actually have a cardiac monitor, and you'll see everything up on the cardiac monitor the whole time today, okay. But during a code situation, when we do connect the patient, be sure we have them connected to the leads also. When I have a patient that's deteriorating pretty quickly, and I have, think that there's a very strong possibility that they're going to code, a lot of times I'll go ahead and put these pads on the patient. May end up, stopping the patient from coding, but I always have them kind of ready. If I think it's a patient going down fast, I'll go ahead and have my pads on. That way when it does, you do get to a code situation, it's easy to just hook the patient. So in the ER, we do that quite a bit. Go ahead and put them on the patient if we think that they're about to code. That way it just kind of saves us a little time. Okay. Does anybody have any questions? Kind of how today is going to work. You will actually be nurses that are working in the ICU. And you each have your role that you've been given today, but the roles won't actually, except for the primary nurse. Who's the primary nurse? Okay. Your role will actually start right off today. But what will happen is you'll come in, you'll receive a report. The patient will be coming to you from the emergency room. So you'll get a report on the patient, and the patient then will be under your care and the intensive care unit. He's a very sick patient with a whole lot going on. And this scenario will probably run close to about an hour. And you will be getting a whole lot of orders. You will actually be making phone calls. I'll play the role of the physician. You'll be getting orders from the physician over the phone. Y'all need to have teamwork. If you say, hey, I think you need to call the doctor, if you don't think the primary nurse is doing it, y'all work together. So you'll be getting a lot of orders. You'll be carrying out a whole lot of orders. You'll be doing a lot of different skills. You'll actually have physician orders right off the bat, so you need to try to take a look at those together. And you need to decide what needs to come first, prioritize those orders. Y'all will all be working together initially, okay, to get things going. And then, like I said, when the patient does eventually code, that's when you'll kind of fall into the roles that you have for today. I will tell you, you're going to be doing a whole lot for this patient before he codes. You're going to be trying to keep him from going into a code situation. So don't try to get the code out of your mind, because that's not going to be happening for a really long time. You're going to, today be working together, taking care of a very critical patient. Okay? You have a lot of IV meds that you're going to be hanging. Like I said, different skills that you're going to be doing today. And you'll be calling for x-ray results, getting x-ray results. You'll have lab values. I want you all to kind of gather around and look at the lab together and try to see if you can figure out, hey, what's going on with this patient. Okay. So, and then just have fun. Today's just a learning. We want you to just, take a deep breath, relax, and it's a learning experience. Okay. So we want you to learn from this, because you don't get to participate as a student. You don't really get to participate in a lot of codes, and also you don't get to participate in taking care of a patient who's in critical condition. Oftentimes you get to observe when you go into ICU, but you don't actually get to participate in that process and take care of a patient whose condition is declining rapidly. So it's just going to make you a little more comfortable when it does happen for you when you do graduate and start working. And then too, you'll have some exposure to a code situation. Okay. I want you to know that we try to make the simulation as absolutely real as possible. So you'll actually be pushing drugs today. You will, don't forget the basics, your assessment and things like that, and talking to the patients, and then we'll be talking back to you, okay? Now, there are some things that we cannot simulate, like, the color of the skin, or, the temperature. We can, make the patient look a little diaphoretic, things like that, but there's some things we can't do, or cap refill. So as you're doing your assessment, you can ask us those questions. Any question about an assessment you think is pertinent, okay? what is the cap refill? What's the skin temperature, color? What are pupil size and reaction? So you can ask those questions, and you will be able to hear things like vowel sounds and heart sounds and lung sounds and things like that. Okay. One other thing, you will be able to palpate pulses as well in certain places on SimMan, but during a code, we always check the femoral pulse during a code. Okay, so when I ask you during the code situation, do I have a pulse? What's my rhythm? You'll look at the monitor for your rhythm, and then you'll palpate the femoral pulse, or the femoral artery for a pulse. And actually there is, you can palpate that on Sim if there is one on SimMan. So, okay. But any specific questions you have about the assessment, you can ask us. And we will be in the room for you, and we're going to be there to kind of help guide you a little bit if you need it. But we're not going to, but yeah, we'll help guide you and assist you, and kind of help direct you, because a lot of this is kind of new, kind of help direct you a little bit. Okay? But I want y'all to work together as a team, and that's the important thing. Okay? So the primary nurse, good delegation for you. Okay? You guys ready to start?
Sure.
Okay.